Hello, everyone. I am Dr. Latrice Faulkner. As Robert so graciously stated, I spent many years in the laboratory behind the bench as a researcher in the drug discovery in diabetes and obesity space. I decided to transition into administration, and then I came across this amazing organization. I know a lot about diabetes and the mechanisms behind it, but I never stopped to think about particular complications. And vision loss was one of them that I didn't really know about until I joined this organization. And I became immersed into the patient population, patient community, and the stories stopped me in my tracks. I had a very visceral response to some of the patient testimonies and stories that I come across in support groups. When you see someone your age that looks like you, that have kids that are young like your kids, and they're talking about not being able to take their kids to school or not being able to go on trips with them and play games with them because they can't see because of this complication, it becomes really, really real. And it drives the purpose and it drives the mission. So for this particular panel, I know every year you guys, we always start with a patient story, a patient advocate who wants to tell you about their experience with this particular complication. But this year we're going to bring together a very unique panel of people that have different perspectives within this particular complication, down from the fear, living with the fear of development of this complication because they have type 1 or type 2 diabetes, to clinicians that have boots on the ground within the under-resourced communities and how we can engage them, educate them, and encourage them and find solutions to the gaps that exists when in terms of access to care, or a young medical student who has put a lot of work and a lot of energy into implementation into these rural clinics of screening methods that are currently available. I just wanted to give you guys the opportunity to hear directly from people that are making moves in this community. And I also, again, want to point out, we are hosting the very first patient-focused drug development meeting, working with the FDA. And this is a very, very, very important project for us. If you guys, any companies that are interested in helping to support us in these efforts, please reach out to me. Any patient advocates that are out there that want to be a part of the panel and give their story, please reach out to me. In this meeting, we will have a panel of patients, not only patients, but caregivers, individuals with diabetes type 1 or type 2, sort of give their stories on their living day-to-day with the disease and how it's impacted their life, as well as their experience with the different treatments that are currently available. And the deliverable from this meeting will be a Voice of the Patient report that will be available on the Mary Tyler Moore website, as well as the recording from that meeting that's scheduled to take place February 12, 2026. And with that, I would like to introduce Emily Cole. She's gonna lead the Listening to the Communities section. She is a very, very important piece to the Mary Tyler Moore community engagement. She's one of our anchors. She's a volunteer, and she gives her time and energy to helping us bring the patient experience and the patient voice forward.
Good morning. My name is Emily Coles, and I have type 1 diabetes. And last Thursday, I woke up real early with an absolute swarm of bees flying around in my head. Jittery and dizzy and nauseated and short of breath, kind of like I am now. And real tired, kind of like I am now, but not as over-caffeinated as I am right now. And I knew that I was on the verge of a panic attack. And so I got out of bed, because staying in bed doesn't help. And I made myself a cup of tea, which also doesn't help. And I sat down to meditate, which can help if you can manage to do it. And I sat in my special meditation position, like I've been taught, and I tried to get in touch with my breath, which was like this. Do it with me so you can all feel this with me. All right? Put your hand on your chest. I can see you, and I can see whether you're doing it or not. And I tried to slow it down. Just like I'm doing now. And in those 20 minutes that I had set for myself with a timer on my phone, I wasn't able to slow it down. In fact, it got faster. And I got dizzier and more nauseated. And so when it came time to stop, I decided to do what any average middle-aged person who's able can do and go see my mom and dad. They live close to me, thankfully. They are both well. Some of you know my father, Dayton Coles, who is a very fierce diabetes advocate as well. Although he doesn't have diabetes, I am his muse. And I walked into their house, pulling myself together, putting on a strong face so as not to concern them. And I took one look at my mom, and I burst into tears, because she's my mom. And when I look at her, I cry. She brings out all the stuff. And she gave me a big hug and said, "Oh, honey, what's going on?" And I said, "I don't know. I woke up like this. I don't know why. And I can't seem to get out of it. I can't seem to stop it. And I don't know what's causing it." So we sat down and we talked a little bit. And then I realized what was going on. I was scheduled for an ophthalmology appointment that afternoon. And my system was gearing up. And I hadn't even realized it. I was teetering in panic over that doctor's appointment. Now, I was diagnosed with type 1 in 1978. I was about to say 1947. I've had diabetes for 47 years. It'll be 48 years this coming June. And so I would consider myself and my perspective to be old school. Old school diabetes, diagnosed way before it was cool. We couldn't test our blood sugar at home when I was diagnosed. I was sent home with a diet, a very strict diet, and an insulin plan that was not responsive to blood sugar, because what was my blood sugar? Nobody knew. And crossed fingers and prayers is kind of what we had. And also an expectation that I would develop complications pretty young. My vision would change, my kidneys would change, my heart would change, my fingers and toes would change. And I grew up with that information. I grew up knowing those things to be true, that I was going to be different from my peers, that what I could do was going to be different than what my peers could do because I had this condition. And so, looking ahead to this ophthalmology appointment, I was already feeling those things, which frankly, I don't have. I've made it this far with none of those complications. Not a one. Thank you very much. But I didn't know that entirely going into this appointment, because maybe this was going to be the year that my luck ran out. Maybe this was going to be the time that I had finally had high blood sugar one too many times. Because we don't know how many times it takes, and it's different for everyone. Do I get to have a blood sugar above 300 4,000 times before my eyes start to change? Do I get to have a blood sugar above 300 10,000 times? And how many times has it happened? Happened last night. Happened yesterday. Happened the day before yesterday. Happens all the time, and we don't know how many times we get. I don't know how many times I've had that. I don't know how many times Candyce's blood sugar has been above 300. I don't know for anybody here. And with our current research, we have no idea how many of those breaks we get. So this time, when I saw Dr. Zadie, was he going to look into the backs of my eyes and be able to see that I'm perimenopausal and it's affecting my blood sugar? That my 15-year wonderful romantic relationship is in an existential state right now, and it's affecting my blood sugar. And that in the sadness of that, I have sometimes sought the company of my friends, Ben and Jerry. And it has affected my blood sugar. Have I finally tipped it over into a point of complications? Dr. Zadie looked in the backs of my eyes and said, if you hadn't told me you have type 1, I still wouldn't know. So I am a lucky, lucky minority who can go as long as I've gone, 47 years with type 1, and with blood sugars all over the place, all the time, even with the best education and the best technology and the best possible access to medical care. All over, all the time. I'm above 300 right now. But I've made it this far without complications. And in the field of diabetes research and complication research, we have no idea why. And we have no idea when my luck will run out. So, in this old school patient perspective, part of what I want to convey to folks is we need some information. Because in what I would call kind of a new age world of diabetes, there are lots of people who come at it with this fantastic vigor and excitement and positivity about what we learn from having diabetes, that it makes us stronger, which I believe it does, that it teaches resilience, which you have no choice but to learn, that it teaches us willpower, like absolute steel. All these things are true, and these are things for which I am incredibly grateful. But on the day-to-day, in the average life of a person, or at least this person that is Emily Coles, I don't feel strong and tenacious and grateful. I feel scared shitless. I am terrified to go grocery shopping because of the insulin reaction I had in a Costco years ago. I'm terrified to take a nap on the sofa because of the insulin reaction I had while napping on the sofa with my partner in the safest place I could possibly be. And I woke up unable to speak and convey to her that I was in dire need of help. It's a terrifying condition, and the consequences of it are terrifying. And that is the piece of having diabetes that I experience and that I feel every single day. All day. And I imagine that there are some people in here who have diabetes. Please raise your hands if you have diabetes. Hello. That some of you maybe can relate to what I'm saying. even though we are different people with different experiences. So now I'm going to introduce the panel. Thank you all very much. I am very excited to introduce Dr. Angela Elam, MD, Assistant Professor of Ophthalmology and Visual Sciences at the University of Michigan.
Thank you.
Welcome.
Thank you. Good morning to you all. So nice to be here. Thank you for inviting me. Those of you who have young children who are coming off of a weekend fueled by lots of sugar will understand that I have no energy and I'm going to stand right here and deliver this talk. I have no commercial disclosures, but always like to acknowledge my funding sources, the NEI, Research to Prevent Blindness, and the CDC. As Dr. Meehan said, I don't have to tell you all about the epidemiology of diabetic eye disease, but I will anyway. We know that it's the leading cause of blindness in working age adults. And just in a couple of years, it will reach upwards of 16 million Americans. And yet early detection is critical. About 94% of vision loss and blindness from diabetic eye disease is preventable. And so early detection is key, yet at least 50% of people with diabetes do not receive dilated eye exams as is recommended. We also know that disparities in this space exist. So racial and ethnic minorities are at greater risk of losing vision from eye diseases like diabetic eye disease. We also know that Americans with lower socioeconomic status are at higher risk for underutilization of eye care. And so when those two things intersect, you end up with people who need eye care the most being the least likely to receive it. And so knowing all of this, what do we do? How do we get the information that all of you are generating in your labs, all of the genius from this room today? How do we get that information to the people who need it most? I have always believed that the way that we do that, the way that we address these disparities, the way that we move closer to health equity is through the community. And community is defined in many different ways. It may be defined by your skin color. It may be defined by your religion, by the language that you speak, by the geography. So the way that we implement programs may look different in rural Virginia, where I spent a good bit of my childhood, than it does in Detroit, where I live now. I partner with faith-based organizations to try and increase eye care utilization, and that may look different in a predominantly Black church than it does in a synagogue or a mosque. And so we have to think about diversity in the truest sense of the word when we want to get our knowledge and data out to the communities that need it most. What is community engagement? Several years ago, the World Health Organization developed an entire booklet, or if you will, on the definition of community engagement. If you use that QR code, it'll take you to it and you can read it another time. But they define it as a process of developing relationships that enable stakeholders to work together to address health-related issues and promote well-being to achieve positive health impact and outcomes. We can do that through research. We can do community engagement through clinical care. This is my dear friend, Kristen Harris Waniwu, who is a native of Ann Arbor, Michigan, an alum of the Kellogg Eye Center's residency program. She's a retina specialist. She's a health equity researcher, specifically trying to prevent blindness from diabetic eye disease. And her key focus is in community engagement. The QR code will take you to her lab and show you all the wonderful work that she's doing. So even if this organization doesn't partner with her, there are lots of things to be learned from her work. When she was just starting out, she wrote a systematic review on community engagement in the eye care space and really focused on making sure that we are receiving direct input from key community partners, that we are soliciting community feedback when we're creating our programs and interventions. And by doing so, that allows us to facilitate trust and partnerships between researchers, clinicians, and the community. when it comes to clinical care, we have to continue to think outside of the box. And so it's been exciting for me as a person that's interested in health disparities and health equity to see over the last 10 to 15 years that we are really starting to move outside of the walls of the universities and our clinics to start thinking about non-traditional ways that we can meet the community where they are. And whether that means taking a mobile van to underserved communities or putting non-magnetic cameras in FQHCs, these are the things that we need to begin to think about. And really expanding our care to the areas of greatest need. And so again, partnering with established community entities like faith-based organizations or just trusted community sites within different community spaces, community health clinics, and I know that there is a push by the AAO to really explore the opportunity to increase eye care utilization in federally qualified health clinics. But I think the ultimate goal is to get to the place where the community is leading the research from the planning phases, implementation, evaluation, and certainly dissemination of the information that we develop during that research. That looks like allowing the community to define the agenda. So oftentimes we, in our research, in the universities, in our organizations, companies, we may have the resources, but we may not have the know-how of how to really get the information out there, how to collect the data. And so partnering, having equitable partnerships with community leaders, community members, I think is critical. And when we do that, we will be able to comprehensively collect data. So you may hear or may have heard about underrepresentation in things like clinical trials and in research in general. I believe that when we're partnering with communities, we will have less of that because there will be a bridge between the researcher or the clinician or the big company and the community. And when that bridge is there, trust is established and we are better able to collect the data that we will need to then help those communities. Allowing the community to be involved from start to finish, I think will also increase the likelihood that our research and our initiatives will lead to direct action and social change, which is the goal, at least it should be. And when community is involved, they are empowered to continue these efforts, and it builds the capacity of the community to sustain these initiatives, which is another critical part. Oftentimes, particularly in the research space, when the funding runs out, the initiatives or the programs run out that are based in the community. And so when we are partnering with community, when we allow ownership, that then builds the capacity for these things, these initiatives and programs to be sustained. Lastly, I'll just end with a few years ago, the AAO developed, or we spent a good bit of time putting together a roadmap, if you will, for researchers and clinicians on the disparities in eye care, but perhaps more importantly, we tried to develop a roadmap on how to address some of these disparities that exist. And so while it is not specifically focused on diabetic eye disease, I do believe that it may be worth taking a look at this paper and finding little areas in which you may be able to, as an organization, put a dent in the vision loss that affects people with diabetes. Thank you so much.
Thank you, Doctor. Okay, now I'd like to introduce our other panelists. I have Candyce Norris Jenkins, person with diabetes and the diabetic mom coach, and Adam Leone, MPH, MD, class of 2026 at the University of Cincinnati College of Medicine. Please join us. To start out, can you each introduce yourselves briefly? Let's start with you, Candyce.
Sure. Hi, I'm Candyce Norris Jenkins, also now known as the Diabetic Mom Coach. I'm a diabetes wellness coach for women, and I've been living with type 1 diabetes for, it'll be 30 years in 2 days. So happy to be here. Thank you.
Hello, everybody. My name is Adam Leone. I'm a dual degree MD-MPH student at the University of Cincinnati. In completing my Master's of Public Health degree this past spring, I had the opportunity to work with the Cincinnati Health Department to design a diabetic retinopathy screening quality improvement project. And as part of that, I had the opportunity to dive into the literature to see what some of the barriers patients report facing are when they're accessing these screenings. So I'm very grateful for the opportunity to be here with you today to share some of what I learned.
Thank you both for being here. Adam, I want to start with a question to you, and you just sort of gave it a nod already. What are some specific barriers that people with diabetes face in getting screened for diabetic retinal disease?
Yeah, I think there are many. When we're considering some of the barriers patients face to these screenings, I think our mind naturally goes to the barriers faced by patients that already know they have diabetes and are already motivated to prevent diabetic retinopathy, right? These are things like whether or not they have ophthalmologists in their area that they can go get the screening from, or optometrists, whether they have the transportation or financial wherewithal to be able to afford this screening, whether they have transportation, even things like getting time off of work to get the screening. And I think these are all very important barriers that we need to address. But what about the patients that don't even know they have diabetes yet? A very important statistic that I think is relevant to this issue is that 1 in 5 patients first diagnosed with type 2 diabetes already has diabetic retinopathy. And I think we need to reckon with that 20% of the population. For the remaining 80% after the diagnosis of diabetes, there are further barriers to getting the screenings that they need, including irregular follow-up with their primary care physicians who would normally be prompting these annual screenings. Also, whether it's patient or provider, prioritizing other health conditions that are also important to address. These patients have many comorbidities, as all of you are aware. Or it could be something as simple as poor integration of diabetic retinopathy screening referral into the primary care physician's existing workflow. And so there are a lot of barriers, unfortunately, but I'm grateful we have so many intelligent, resourceful people in this room that are working on alleviating some of them.
Thanks, Adam. Candice, over to you. How has your diagnosis with diabetic retinal disease affected your day-to-day life?
Yeah, thanks, Emily. That's a great question. And as you spoke earlier of your experiences and how time was on your side, and thank God that you didn't experience the complications. That's not always everyone's story, and it surely was not my story. When I was diagnosed back in 1995, I was a preteen, and like many of you who are preteens or who have preteens, you remember the stage when you were rebellious against your parents, right? Well, my way of showing my rebellion at the time was, well, I'm not gonna check my blood sugar. Well, I'm not gonna take my insulin. And fast forward through my teenage rebellious years, I was now a 25-year-old adult who was working and being productive in the society. One day I was driving to work, and I was talking on the phone to my sister, and I was taking the usual route that I take to work, and I said, I have to call you back. I can't see. I was sitting at a red light, and everything went completely black. And thank goodness that I was on a familiar route, so I kind of could, feel my way around and kind of know where I was, and I pulled over, and I went to a local doctor's office, and he said, call someone to come get you. I can't let you drive. And so I went to an ophthalmologist's office, and many of you know that's the day I was diagnosed with glaucoma. Many of you eye professionals know that a normal range for eye pressure is between about 10 and 14. Well, the doctor said, I'm sorry, but I can't let you leave my office. Your eye pressure is 52. That was my introduction to diabetes. To diabetic eye diseases. He then diagnosed me with diabetic retinal disease, and I went through everything, the lasers, the injections, the surgeries, everything. And fast forward today, he's still my doctor, that same guy. So shout out to Dr. Sund, who literally changed my life that day. But it makes me think about, just personally, what if I would have never run into Dr. Sund? What would life look like for me? Well, for one, I would have never met my husband? I wouldn't have been able to see that smile every morning. What if I would have never been able to see my children or walk across the stage at graduation or now see all of you to have this experience? Or what about the women that come to me and say, I've been diagnosed now, what do? I would have never been able to show those women the right steps to take now. And then future, what if I would have never seen my child graduate from college or get married? Those are all experiences that I would like for all of you to think about when you're in your offices, when you're doing research in your labs, that it's not just numbers, data on a paper, that these are actual real lives with real people, real results, you know? And I always thank Dr. Sun. He's kind of gone with me now. That was 15 years ago. And so I've now, you know, he's gotten the pleasure of to see me thriving and doing well, and his kids are growing up. But what if he would have never said to me, I can't let you leave? What if he would have let me leave that day? And I always think about, what would life look like? And I just remind those who are living with diabetes and suffering complications like I have. I've also undergone 2 kidney transplants. In addition to that, to smell the flowers. Notice the trees changing colors in fall. We were driving to the airport yesterday, and my husband said to my daughter, look at the trees. What colors are they? And she's going to be 4 next month. So she said, Daddy, it's yellow, it's red, it's green. And then I was able to say, and look at the brown ones, and look at the green over there. Those are the type of memories that I would have never been able to make with my family if diabetic eye disease would have snatched my vision that day in 2010. Thank you.
Thank you so much, Candice. We have 35 seconds left. Are there any questions? We have 2 minutes. I have a couple more questions for each of you, but because our time is so short, I wanted to see if we can take any questions from any of you fine folks. Anyone?
Carrie Getz from TopCon. This is for Dr. Elam. So what is your experience with community screening? So it's one thing to identify the folks who might need therapeutic intervention. In the community screening, you can often identify those people, but then what's the next step to getting them the treatment that they require?
Yeah, that's the tricky part. I think, at least in Detroit, what we found is that there is access. There's access to care. It's just about having the knowledge and the encouragement to get there. So part of we don't just screen, we also have a community health worker that does like a health education program. So we're specifically focused on glaucoma. And so people who are flagged as glaucoma suspects or likely having disease, we put them through an educational program while also getting them in to see an ophthalmologist. So oftentimes that knowledge gap, that health literacy gap is part of the issue. And then, for example, oftentimes people think that in communities like Detroit, urban areas that non-insurance is an issue, but I believe the stats show that about 94% of Detroiters have health insurance. And so it's just about helping people make the next step, knowing that they need to see that eye doctor, and then maybe just helping them get there. We've not had any issues getting people in to see care. I think we've had one person without insurance, but we were still able to get him the care that he needed. So it's just about bridging that gap. And oftentimes it's a health literacy gap that we can help to fill.
Thank you so much. And Candice, thank you for your testimony. That was really powerful. My name is Dr. Jess Sexton. I'm a clinical epidemiologist, and I'm based at the School of Medicine at UT Tyler in East Texas. Listening to the community, we know looks different depending on where you are. In East Texas, if our region was a state, would be roughly the size of Ireland or West Virginia, and we have the same population as Dallas. So we're very spread out and we have a lot of people. And our patients travel far, sometimes hours, for specialist services. And the availability of broadband, like as a basic service, creates barriers to care that really shapes what access really means. And what we've learned through genuine listening from churches, community groups, working with food banks, grocery stores, is there's a need for community-anchored models that can sustain long after funding is gone. So my question for you is, how do you ensure that community voices are not just heard, but are shared back into systems change?
Was that for all of us, or
Yes,
you said
please.
Candace?
That's for everybody.
Oh, have at it.
And I'm afraid we have to make it really brief because we've been told that our time is up.
Oh, okay. I'll try to be brief. Oh, well, that's hard it's a very difficult question to be brief about. But I think these are patients that have valuable perspectives, and if they're having trouble getting basic vision care needs satisfied, they're going to have probably even more trouble going out and sharing their perspectives about those healthcare needs, right? So I think that the responsibility is on us to go seek out these patients and to learn more about the barriers they face and see how we can sort of complement the efforts that they're already making to get their vision cared for. It really is about us using the privilege and the time and the resources that we all have to try to make life easier for those patients. And I think there are a number of ways we can do that, but first we have to have the motivation to do it.
If I could just quickly add that, sorry, I know we're out of time, but often it's really important that we make sure that we are conducting our research in a way that we can translate it to policy. I mean, in my mind, that is the key. We can do all of the fancy things, but if we are not able to get the people with the money to sustain these things, and then oftentimes we've done a lot of work and it doesn't reach the places where we need. So doing your research in partnership with communities, and also thinking about how to create that one pager. So when you go to Capitol Hill, you can be like, hey, this is what we found in our community and this is the impact that we made. We're having difficulty sustaining it, but with your help, congressperson, senator, or whatever, we can change the lives of your constituents. So I think if we often get focused, at least from a researcher standpoint and clinician, on the work that we're doing, but we have to make sure that the excellent work that we're doing then translates to policy so that it can really affect change.